Thank you for joining us. We are now going to start today's webinar. The webinar is being recorded. Before we begin, I'd like to go over a few details for today's meeting. To ensure audio quality for all attendees, we have muted everyone's lines. That means you can hear us, but we cannot hear you. We will hold a Q&A discussion after all of the presentations are finished. To ask a question, please use the chat feature on the right-hand side of your screen. You may have to click the arrow next to it to expand the section. I will now hand things over to Amy Eden to start off today's webinar.
Thank you. Welcome, everyone. We're very excited that you've all joined us today. Again, my name is Amy Eden. I am the Acting Director for AHRQ's National Center for Excellence in Primary Care Research, which is quite the mouthful, so we pronounce the abbreviation NICE-PCR, so I'll be using that from now on. It's my pleasure to welcome you to today's webinar about using large data sets in primary care research. And before we get into our excellent lineup of presentations, I wanted to tell you just a tiny bit about NICE-PCR and what we've been working on. You might or might not know that AHRQ's 1999 authorizing legislation included the establishment of a Center for Primary Care Research that would serve as the principal source of funding for primary care practice research in the Department of Health and Human Services. While AHRQ has funded primary care research since its inception, the work has been sort of broadly dispersed across the agency's centers and not clearly defined into a single portfolio of work that's easily accessible internally or externally, really. About 2 years ago, NICE-PCR became more formalized with that name and also a director. And last year, NICE-PCR received earmarked funding for the first time. And we've been working since then to develop a more coordinated primary care research portfolio and agenda, create more targeted primary care funding opportunities, support and expand a diverse primary care research workforce, and build a more robust and systematic dissemination strategy, among a lot of other things. So next slide. With respect to the dissemination efforts, we're really excited to be hosting this new webinar series, which we've called Strengthening Primary Care Research. Today's webinar will be, again, about using large data sets in primary care research, and it's the first in the series. We're working on the second webinar, which will be upcoming, and you'll start hopefully seeing announcements about that soon, which will be about using qualitative methods in primary care research. Next slide. The goal of today's webinar is to demonstrate how some large data sets can be used to answer different types of primary care research questions. You'll get to see how data from MEPS, which is AHRQ's Medical Expenditure Panel Survey, Medicare claims data, and electronic health records data have been used in 3 very different studies focused on primary care, and then learn a little bit about some advantages and disadvantages and challenges of using those data sets. So without further ado, I'd like to introduce our moderator for today's webinar, Dr. Robin Bloodworth. She's a health services researcher at Apt Associates with a lot of experience herself using large data sets like these. And Robin will facilitate the Q&A and discussion after the presentation. So welcome to Robin.
Thank you, Amy. Good afternoon and good morning, everyone, depending on where you're joining us from today. Like Amy mentioned, I'm a quantitative methods associate in the Research, Monitoring, and Evaluation Division of Apt Associates. And my background is in public health and health services research, so I have experience using large data in primary care research. And I'm very happy to have the opportunity to serve as the moderator for this webinar. So let's go ahead and get started. Next slide, please. First, I'd like to introduce our speakers. We have 3 primary care researchers here today. Each one will discuss some of the large data sets and methods that they used in a recent study they completed. First, we have Dr. Yalda Jabbarpour from the Robert Graham Center for Policy Studies. who will be presenting on the Primary Care Scorecard. Dr. Yong-Fang Kuo from the Office of Biostatistics at the University of Texas Medical Branch will be presenting on the use of Medicare data to identify primary care teams. And then Dr. Annie Elizabeth Larson from OCHIN will be presenting on the effect of rurality and the COVID-19 pandemic on telemedicine and preventive healthcare use. And be sure to save your questions. We'll have a Q&A session after all the presentations are over. Next slide, please. Okay, so now I can turn it over to Dr. Jabbarpour to tell us about the Primary Care Scorecard. Thank you.
Hi, everyone. Thanks for joining. I am Yalda Jabbarpour. I'm director of the Robert Graham Center for Policy Studies in Primary Care and also a family physician in Washington, D.C. So thanks again for being here while I review how we use the Medical Expenditure Panel Survey, or MEPS as I'll refer to it throughout the presentation, to create a baseline scorecard for tracking support for high quality primary care. We did this research that I'm about to show you with support from both the Milbank Memorial Fund and the Physicians Foundation. Next slide. Before I really launch into our use of MEPS for the scorecard, I wanted to take a few minutes to set the stage and tell you why we were even doing this scorecard and what it was meant to measure. So back in 2021, the National Academies of Science, Engineering, and Medicine developed a landmark report on implementing high quality primary care. In that report, they laid out these 5 recommendations that are on this slide here for the country as we move towards improving our support for primary care. In this report, they also called for a scorecard to track how close we were getting to meeting these 5 objectives shown here. So what I'm going to present to you is a couple of measures from that scorecard. There are many more that I'm not presenting. If you want more detail than I give here, or if you want to see the rest of the measures, those that did not include MEPS, because MEPS was not the only data set we used, I encourage you to go look at the scorecard, which can be found on the Robert Graham Center website, as well as the Milbank Memorial Fund website. Next slide. For each of the measures I will present, we attempted to use publicly available data sets when possible. We also were told not to calculate only national numbers, but state numbers when the data allowed for it. This is why, as I'll get into later, we chose MEPS for our data set of choice for these 2 measures. The first measure related to recommendation 1 about paying for primary care teams to care for people and not doctors to deliver services was on primary care spend. The second measure that I'll present to you relates to recommendation 2 about ensuring that high quality primary care is available to every individual and in every community. And that is the percent of adults and children without a usual source of care. Next slide. So let's start with the primary care spend data and the primary care spend measure. So for those of you that are not aware, MEPS is a national survey that samples civilians and non-institutionalized populations. It provides nationally representative estimates of health insurance coverage, healthcare utilization, and expenditures. Many people ask us all the time, how can a survey of civilians in the United States be used for something like healthcare expenditures? After all, most people don't remember the date of their last doctor's visit, let alone how much was spent or collected by their insurance. Well, the data is actually collected in a pretty sophisticated way, and it's collected from 2 sources: respondents, and then providers identified by the MEPS respondents are used to supplement and validate the data. The data, subsample of the data, is also imputed based on known regional costs by age, gender, payer, conditions, and visit type. So if you're a 25-year-old female living in Washington, D.C. who said that you went to the doctor's office for a UTI, there is imputed data that can be used for that as well. Participants aren't doing this blindly. They actually receive an information package that guides them in collecting and recording the services that they received. Another thing to note with how MEPS data is collected is that MEPS uses what's called a panel design. So that data is collected on each sampled household over a 2-year period. Each year, half of the sample rotates off and is replaced with newly sampled households. Each respondent or each household is interviewed 5 times across the 2-year study period. And at each interview, they're asked questions about insurance coverage, health services used, and the amount spent on each of those services. So the nice thing about MEPS is that it's not only is the national level data available publicly for download and use, but if you wanted state level data for the 29 states that it's available, you can actually go to the data center and get that. MEPS is made up of different file types. For our purposes, we actually use the consolidated outpatient and event files for primary care spend. We calculated primary care spend, which I will show you on the next slide, for all payers and each payer type individually, since MEPS does also collect information on this. So here's the analysis we did. So in its simplest sense, we defined primary care spend as the proportion of all healthcare spending that is spent on primary care. For our numerator, we used all billed expenses towards office-based and outpatient visits to primary care physicians, which we defined as family physicians, general internists, geriatricians, general practitioners, or general pediatricians. For our denominator, we used the sum of all expenditures in MEPS, which comes from 9 different categories: office-based, outpatient, hospitalization, emergency department, prescription medications, vision care, dental care, home health care, and everything else. Next slide. And you can see here our results, and they just show how little we are investing in primary care as a nation. Anywhere between 3 and 8%, depending on the payer and the year. Probably as expected, given the health of the populations covered, Medicare primary care spend is lowest, and this likely reflects this population's use of specialty services and hospitalizations, and commercial primary care spend is the highest. Spending for all payer types is lower in 2020 than it was in 2010, with Medicaid showing actually a continuous drop since 2014. One thing to note here and moving forward is that 2020 was an aberrant year for surveys overall, and it certainly was for MEPS as well, given restrictions on how data could be collected at the beginning of the pandemic. So this will actually be interesting to follow to see if the big dip we saw in 2020 is real or just a result of data collection changes. And when I say data collection changes, before 2020, MEPS was collected by actually going and being in person with the household. In 2020, when restrictions were put in place, MEPS was actually conducted over the telephone, which did impact response rates. Here I show you the national data only, but if you're interested in your state and your state level data that we found for MEPS, you can actually go to the dashboard online and look up your state. Next slide. So while MEPS was somewhat ideal for calculating a measure like PC spend on a national level because of its data collection methodology, there were some limitations to discuss. First, we were unable to separate out Medicare and Medicaid HMOs, which does have some policy implications given how these programs are administered are different from straight Medicaid and straight Medicare. Also, the specialty for NPs and PAs, as well as osteopathic providers, is not readily available. So for us, as we know, NPs and PAs, as well as osteopaths, can represent a variety of different specialties, but they can also represent primary care. Because we weren't able to tie them to their specialty using this data, we didn't include them in our narrow definition of primary care spend. And also, as I alluded to somewhat, although state level estimates are available, which makes MEPS very useful, they're only available for the 29 most populous states at this point. Next slide. So let's shift gears now and talk about the other measure we calculated using the MEPS data. This time, instead of focusing on the expenditures part of MEPS, we really focused on the utilization part of MEPS. We wanted to examine what % of the US population did not have a usual source of care. Once again, we used the 2010 to 2020 data, specifically the consolidated files. We used two types of questions, both the do you have a usual source of care question, as well as the where is your usual source of care question, to construct a two-category usual source of care measure. Next slide. So what does that mean exactly when I say a two-category usual source of care measure? Essentially, there are two main questions we focused on. So first, the question that we focused on was, is there a particular doctor's office, clinic, health center, or other place that you usually go to if you are sick or need advice? If they said no, they were automatically in the no usual source of care bucket. If they said yes, we then went to the next question under location, which is, does the usual source of care work at a clinic, in a hospital outpatient department, an emergency department, or some other place? If the respondent said that they were in the emergency department getting their usual source of care, we actually put them in the no usual source of care bucket. For our purposes, we did not feel that the emergency department counted as a usual source of care. And then everywhere else went into the have usual source of care bucket. Next slide. And here's what we found. So using the maps from 2010 to 2020, we found that over a quarter of adults, and 10% of children reported no usual source of care in 2020. Once again, 2020 is a little bit of a weird year, but that aside, over the last few years, we can see that the percentage of US adults and children who report no usual source of care is rising, which is concerning for the overall health of the nation, given how important primary care is to the health of the population. Next slide. Once again, for this measure, there were also some similar limitations. Only 29 states could be used, and there was no smaller geography. For usual source of care, there are so many market level differences at a local level that could impact whether someone has access to a PCP or not, but we weren't able to get that granular with the MEPS data. Also, when we tried to determine the discipline of the provider, as I've said before, we found that nearly 90% of the respondents in this usual source of care questionnaire reported a physician as opposed to an NP or PA, which we think is probably an over-report. It seems a little unusual. It may be because of the self-report nature. Patients might not know that their nurse practitioner is not a physician or that their PA is not a physician because that's who they go to for their usual source of care. Also, the usual source of care question changed in 2019, 2018. It was just asked slightly differently, which is likely, it could explain why we see that bump in 2018 in the previous slide. Next slide. Overall, though, there are several opportunities to talk about in using MEPS for data analysis. It's extremely policy relevant, given that it collects data on coverage, use, and expenditures, but also on self-reported health status. So this individual level data allows for examination of cost and how the increased or changed use of healthcare services affects reported health status, for example. This was especially important after the Affordable Care Act was implemented. MEPS is the only national survey that collects data on all these areas. It's also rich in outpatient data, not only on use and expenditures, but also on ability to access care. For us, this is perfect for many of the issues impacting primary care. And finally, there are really strong validation methods. So even though this is a survey and self-reported, the ability to validate a subsample with providers in the provider file is important. Next slide. But MEPS also comes with some challenges. First, the sample size of MEPS is too small to support some important analyses. It collects data from about 14,000 families, and that does limit state estimates, particularly in those 21 least populous states. Because of the limited sample size, even in the larger states, the 29 states that we can get data for, it does not allow us to describe specific demographic groups within most of those states. Also, because of the two-year panel design I referred to, analysis can be challenging as half the sample rotates off each year. And finally, I've said it a couple times, but determining the specialty of practice for non-physicians remains a problem. But nonetheless, this is a very important and relevant data source for policy-related analyses, particularly in primary care, like the one we did, but it needs a lot more support in order to continue to strengthen and grow. Thank you very much.
Great, thank you so much, Dr. Jabbarpour. And as a reminder, we're going to save questions until the end of the webinar after the other two presentations are completed. So go ahead and you can enter them in the chat, but we'll answer them later. And now I'd like to introduce our second presenter, Dr. Yong-Fang Kuo, who's going to present on the association between health care and health outcomes using social network analysis. Over to you, Dr. Kuo.
Okay. Thank you very much to join this webinar. I'm very happy to share, our study with you. I'm the director of Office of Biostatistics, also the professor and the chair at the Department of Biostatistics and Data Science at the University of Texas Medical Branch. This study is funded by, AHRQ R01, which we study primary care provided by a nurse practitioner. So this particular study I'm going to present today is try to assess the association between team structure and the health outcome cost using a social network analysis. Next slide, please. So nurse practitioner and the physician assistant has become increasingly, important member for the primary care team model. Previous study compare, care provided by the practice have physician only, and compare with the, team with NPPA show, better health outcome and the lower cost of care. However, those study, they are very limited study going deeper to examine the degree of the team collaboration, team connection, and the dynamic of NPPA, how they interact with others, how this relate to the team care. So that's why we conduct a study. Next slide, please. So we in this we using the social network analysis. So social and network analysis actually use a lot of to study friendship, also in business setting to study how workers collaborate together. However, this method also being used, not many, only few study using in healthcare field, and then we may be the first one using the social network analysis to study NP and the PA in primary care. So SNA is using graphic theory to visualize and quantify this network of the participant. In here, it's a provider, MD, NP, and the PA through the mapping information and also their communication pathway. So Dr. A connect to Dr. B connect to NPC, so this pathway can be tracked in our data. And the SNA also, there are several measures. So we are choosing 3 measurements to study, provider connection. The first one is edge density, which is measure degree of collaboration care or how they connect to each other. Second one is called degree centrality. So this is measure how decision making is centralized. The third one is called betweenness centralization. So this one is measure degree to which information share is whether those information is centralized or not. Next slide, please. So this is the example which we did using a county of data in Texas to show how we using social network analysis. So we have the blue dot from MD, red dot from NP, and then black dot from PA. So based on their number of share of patient, means both providers see same patient, and then we get those connection between those providers. And then then we using the algorithm to get each practice tip. So this is just an example to show. Next slide, please. So the data which we use to do this analysis is Medicare data. So Medicare data is a billing. So we're using several different files. So we're using a beneficiary, summary file. So this data including patient demography and also their enrollment information. We're using outpatient claim file, which are called outpatient statistics analytical file and the carrier file. One is the claim come from outpatient facility. The other is a claim come from is a professional bill. And using those to identify outpatient visit, also preventive care visit, using the CPT code. And then we're using, besides those two files, we're also using the inpatient file, which is called Medicare Provider Analytical File. From there, we can identify hospitalization, and combined with the OCHIN carrier, we can identify ER visit, and the sum of them, we also can calculate total cost of care. And we also using the Ph.D, those are prescription file, which we can study potential inappropriate medication use. So those are the file we use. And the very previous speaker talk about, it's very hard to identify, NP and PA in survey data. So in Medicare data, there are specialty code. So we can define primary care physician based on, like a family FP, internal medicine, geriatrician, group practice, or those from specialty code. We also can identify NP and the PA based on specialty code. However, NP and the PA also conduct a specialty care, which specialty code doesn't distinguish. So we're using another file. It's called National Provider Identification Registry. So from there, we can using individual NPI, the National Provider ID, link to this file in order, based on the taxonomy code, which we can narrow down to the NP and the PA they providing primary care. So that's what we identify primary care, NPPA, and the primary care physician together in order to do the social network analysis. So next slide, please. So our study, because we want to knowing number of patient share between provider, so we would like to get 100% of Medicare data. CMS do not provide 100% outpatient care data to any researcher. So the way we do is we add 200% data. The first 100% data which we request is 20% randomly select primary care service area. So primary care service area is defined by Dartmouth Atlas. So they have 3 levels: hospital referral region, hospital service area, and then the lowest one is a PCSA. So we random select 20% of PCSA, so it's 1,400, and get 100% of the patient on those PCSA in order to do the social network analysis. So we in each PCSA, we identify all the primary care visit and the prevention visit provided by primary care provider, and then all the provider, they have at least share with another provider at least 30 patients. We are including them to do social network analysis. We think each PCSA, we do the using the algorithm under the SNA, which is called Work Trap Community Finding Algorithm, and using those to identify the practice within each PCSA. We allow 4-step random walk, means the connection can be up to 4 steps. And then we also weighted the number of patients shared by 2 providers in order to build this the network within each PCSA. Next slide, please. So after we do those social network analysis. So out of 1,400, we find 559 PCSA met the modularity of greater or equal than 0.4. In the social network analysis, this modularity level means that they are connect well and modularize, so we can have identify good practice within that PCSA. And for each PCSA, we select 4 types of practice: MD only, MD work with NP, MD work with PA, and the 3 types of provider working together. We exclude those practice only have NP only, or only PA, or only NP-PA. It's very small, so we exclude those practice. Then the second selection data is another 100% of Medicare data. So among those, we get 100% Medicare data for patients with diabetes, heart failure, also with COPD. So we link this 100% patient with those 3 chronic diseases to the practice which we identify from SNA in order to do analysis. So our study cohort come up have about 450,000 patients cared by 17,185 primary care providers in 4,453 practice in 556 PCSA. There was 3 PCA excluded because they are too small after this selection. And then we're using the 3 measures which we described earlier to measure the connection between the provider within each practice. Next slide, please. So our analysis we do multi-level general linear model because we have patient nested within each practice. And then we're using the log link function for the binary outcome, such as hospitalization, ER visit, and the potential inappropriate medication use. And we're using a log normal distribution model to study the cost ratio. Next slide, please. So our main finding. So our main finding, we find that age density, which are highly higher age density is associated with lower odds of hospitalization. Also lower odds of emergency room visit, and also lower spending. So it means, so if they are highly collaborated, so those practices will have, better outcome. So based on the degree of centralization, which those are how the decision is making is centralized or not, then we find that, higher centralization of decision making is associated with a higher rate of hospitalization. ER visit also have higher spending. And it is also, there's one interesting finding, which we find that, this centralization actually have lower rate of inappropriate medication use. Because we believe, because centralization may be helping them to do medication reconciliation, which reduce, the polypharmacy or drug-drug interaction. And we also find, higher between centralization, which means the higher centralized information share is also associated with increase of spending. In our study, we also, average, the degree of centralization for each type of provider, like NP and the PA. So if the practice having both MD and NP, so we compare those average, degree of centralization between NP and MD, decide who are lead the practice. However, our study find regarding its, NP or MD leading the practice, the hospitalization, ER spending, there's no difference. Next slide, please. So the data which we use is Medicare data. So Medicare data, definitely, there are some limitations. The first limitation, since we are using, both Part A, Part B, inpatient, outpatient claim, also, the prescription data. So these are only for fee-for-service Medicare population. So our result cannot generate to Medicare Advantage plan. We also cannot generate to commercial insurance. And most of patients definitely is elderly here, so the practice do not apply to younger population. Second, Medicare data, there are some kind of maybe incorrect in some billing or missing some information. The first thing is very important to start when we study NP and the PA. Because NP and the PA, they can be providing service under the supervision of physician. And the BO is under the physician, not the NPPA. In that situation, so we will underestimate the care provided by NP and the PA. Second, this is BO, so it's based on procedure code. So procedure code usually is very good in the claim data. The diagnosis code usually the primary diagnosis associated with the billing procedure is also good. However, some of other diagnosis code maybe is incomplete, especially in outpatient. It's only up to 4 positions, so maybe not all capture all the diagnosis. And in Medicare data, we did not have individual patients' education, marital status, income. We always using a surrogate. So we merge with zip code information from census to get like a percent of population under poverty line, at the zip code level as a surrogate to measure socioeconomic. There's no health behavior, in the Medicare data, but you can use, some of diagnosis code to measure obesity, smoking, but can be underestimated. However, the strength of using Medicare data is the sample size is very large, and it's represented in all the U.S. region, so you can use. And the other good things is, because we Medicare data have the real NPI provider ID, so we can merge provider ID to other file. For example, like the provider practice specialty file, the ACO provider file, or physician compare file, which you can get the quality of care by provider, also year of experience, which year they graduation, the age, gender for physician or NPPA is in there. You can. The good things also, in Medicare data, is we can do multi-level structure to evaluate health system. Patient nesting on provider, nesting on hospital, or patient nesting on practice, nesting on region, those can be studied. The other good things is longitudinal. Once patient all in fee-for-service, we can follow up longitudinally to see their outcome. Next slide, please. So the overall study, there are some limitations. The first is, we do not using telemedicine to study, share care. The second is this identification of team care using social network analysis. It's very specific. So that means, it's very good. However, it's not, kind of, sensitive. Some of practice, cannot be identified well, especially in the place which have lower population and also lower income place. We have another paper published to identify those limitations. And also, we cannot distinguish the NPPA. They are substitute for the MD, or they are complementary skill to the care provided to patient care. They cannot be, they require some qualitative study. This particular study is a cross-sectional study. So in the future, definitely, looking for longitudinal how the social outcome is very important. Thank you very much.
All right, thank you so much, Dr. Kuo. And again, we'll save our questions for the end of the webinar. Now I'd like to introduce our third presenter, Dr. Annie Elizabeth Larson, who will present on rurality, COVID-19, telemedicine, and preventive healthcare use. Over to you, Dr. Larson.
Thank you, and thanks for joining. Next slide, please. I would first like to acknowledge and thank AHRQ for funding this research. Next slide.
So rural patients have higher rates of chronic disease, infant mortality, ambulatory sensitive hospitalizations, and age-adjusted mortality than more urban patients. And use of primary care services can reduce all of these things and can help improve self-rated health. However, use of primary care among rural patients lags behind that of more urban areas. And telemedicine is a tool that has been identified as a means for increasing access to care for people living in rural areas, many of whom face really distinct challenges in accessing those services, such as driving times or distances, limited transportation options, and a lack of healthcare providers. Next slide, please. So the wide-scale adoption of telemedicine resulting from the COVID-19 pandemic presented this opportunity to really understand if telemedicine can equitably improve preventive care utilization, as well as quality of care for patients across the urban-rural continuum. However, early evidence suggests that rural patients are not utilizing telemedicine at the same rate as more urban patients. And additionally, little is known about the quality of care and what telemedicine modalities patients in rural as compared to more urban areas are using. Next slide, please. So the research aims for the study for this overall grant are as follows: just to assess changes in frequency of preventive care visits and the method of care received among urban and rural patients, understand differences in the use of telemedicine and then the type of healthcare for which that telemedicine is being used, and then also understand the effect of telemedicine use on the quality and equity of care for chronic physical and mental health conditions among rural and urban patients. And so, next slide, please. This study is just in its first year, so just getting started, and starting out by looking at kind of these questions related to who is using what telemedicine modality. And by modality, I'm kind of referring to video or audio visits, also kind of separating out e-consults or remote patient monitoring, and then understanding what conditions they're using those modalities for, trying to understand if quality of care differs by modality. So kind of overall, how do telemedicine modalities provide care in different communities and among different patient populations? And part of the reasoning for this is that, or kind of my interest in this is that CMS has ruled that they are no longer reimbursing for audio-only visits after the end of 2024. And they've stated that part of this decision is made because of the limited research on the effectiveness of audio-only visits as compared to an in-person visit. This does have the potential to further exacerbate disparities in access to and use of healthcare among patients who are already less likely to utilize needed and recommended care, such as rural patients and low-income patients. Next slide, please. So for this research, I am utilizing electronic health record data from OCHIN's data warehouse. And OCHIN has data on community-based health centers that serve safety net clinic patients across the United States. So that includes clinics that are local health departments, some private clinics, academic health centers, rural health clinics, but it's primarily made up of federally qualified health centers. Next slide, please. So this is a very short list, but some of the available data includes demographic data on the patients, encounter, diagnoses, procedures, vitals data, labs, medications, some patient-reported outcomes from screening questionnaires, immunizations, and then patient-level social determinants of health from social needs screenings like PREPARE. And then in addition to what this very short list includes, I have access to a lot more information like chart notes or scheduling information or billing data. The list is endless. Next slide, please. So OCHIN has a single instance of EPIC, and what that means is that the record follows the patient across any OCHIN clinic. And this results in a robust longitudinal data set. So the data I have presented here is as of the end of 2022 for what are considered active patients. And by active patients, I mean patients that have had a visit in the last 3 years. So there were 5.6 million patients in the data set that were seen in 1.4 or 1,400 clinics within 177 health systems across 31 states. And I can say that this data is already out of date. As far as I'm aware, there are already at least 2 additional states that have been added in, and I don't know how many health systems and clinic sites that includes. Next slide, please. So one of the really unique features of this data set is that it allows us to examine patients who are uninsured and the care that they receive while uninsured. And this is particularly important when thinking about rural health research, since rural patients are more likely to be uninsured or Medicaid insured. So as you can see, about a quarter of patients included in this data are uninsured, over half are Medicaid insured. And then the other 20% are kind of a mix of other public insurance, Medicare, TRICARE, Indian Health Services, or have private insurance. But as you can see from the chart on the left, many of those are likely either eligible or are purchasing them through state or federal marketplaces, since almost 55% of patients live below the federal poverty line. Next slide, please. So 83% of patients can live in an urban area, and then the other 17% live in a rural area, I guess, depending on how you define rural. This is compared to 14% of the 2020 US population identified as being rural based on the USDA Economic Research Center. And so this, as you can see, is like slightly maybe oversampling rural patients, which benefits me in my interest in rural health research, which may be sometimes undersampled in other data sets. I will also note that patient addresses and patient address data are available in the OCHIN data, and I was able to link those to rural urban commuting area data files, which is what's giving these numbers here. And then that also means that I'm able to link those to American Community Survey data to utilize contextual and environmental information. And these percentages mostly reflect the makeup of where clinics are located as well. Next slide, please. So as I mentioned, these records are linked across clinics, resulting in this longitudinal data set. And what that also means is that it creates this nested structure. So we have encounters nested within patients, within providers, within clinics or health systems. And because of this nested structure of the data, a lot of the research conducted at OCHIN uses a multi-level modeling approach, which is something that I will be doing for analyses. Next slide, please. So kind of back to my initial questions and what I am starting to look at in terms of identifying telemedicine modality. There's really limited research on this, and it's been a bit mixed depending on the data source, whether it's coming from survey or claims or electronic health record data. And so it seems hard to kind of get a grasp around like how much is actually being used of each of these different modalities. So as an embedded research, one of the benefits I have is that I am able to get input from individuals across the organization. And so I've already had conversations with clinicians and informaticists, the individuals who are helping build and design the electronic health record system, billers, and then a host of other people to figure out what information I should be utilizing from the electronic health record to identify this modality. This information is stored in many different places in the electronic health record system, such as when the visit is scheduled, during the encounter, or when it is billed. And I can note that the information stored in all these places can and often does differ. So having access to these experts across the organization really helps me understand how to use this information best to assign modality. Next slide, please. So some of the strengths of utilizing this data, it contains data on patients who are often not captured in other data sources, such as uninsured patients. And as I already mentioned, rural patients are more likely to be uninsured. So it does kind of allow for the study to be slightly better powered. It also has this single patient record across the system, allowing for longitudinal analysis at the patient level. This could also be rolled up to provider or clinic level analyses, really depending on the research question. And then another thing that's of benefit to me is that this data is geocoded, and it will allow for spatial analysis methods and use of contextual and neighborhood level data. As I mentioned, it is linkable to external data sources to provide those contextual factors. I've already linked in RUCA codes and then some ECS data that I will be using. Next slide, please. Some of the limitations. I only have the data available on the care that is received in these clinics. This is outpatient data only, so I don't actually know the types of services that are being received in inpatient care. I do have the ability to link, as I mentioned, to external data sources for additional detail. Some projects being conducted at OCHIN have linked to Medicaid claims data or cancer registry, vitals data, all payer, all claims data. That's not something I will be doing for this project, but maybe for future research. Other limitation is that these are different systems and different practices. While they do share this single instance of EPIC, it may result in differential data completeness and quality. However, as I mentioned, most OCHIN clinics are FQHCs, and they have very specific reporting requirements. So many of these data elements are really well captured because of those reporting requirements. And then, as I also alluded to earlier, there are new health systems continually being added to the OCHIN network. And this can kind of create some challenges and in terms of like figuring out what to include or exclude from your research. And then, as I mentioned, there's kind of this confusion, and sometimes the information documented around telemedicine modality can differ depending on where it's documented. This is really where these conversations with other team members, people who are actually practicing in the clinic, informaticists, people who are building these tools, can help to validate that information. And then one additional step that I still have yet to do is to complete a handful of chart reviews to really verify the data. Next slide, please. So some future directions, kind of as a next step after I'm able to identify the telemedicine modality, is to start looking at quality of care and to understand whether there are certain conditions that are better suited to telemedicine or specific telemedicine modalities than others. And then thinking about longer term outcomes, as I mentioned, OCHIN data is limited to outpatient data only, so extending this to include inpatient claims data, looking at hospital data to think about some of those longer term outcomes. Thank you very much.
Thank you, Dr. Larson. So we can go to the next slide now. Now we can transition to the Q&A portion of the webinar. And first, we'd like to say thank you to all audience members for your questions. And even if we don't get to your question today, please know that we use all questions in these webinars to inform the content for future AHRQ primary care webinars. And also feel free to email any questions directly to our presenters at the email address shown on the screen if you prefer. So before we get into specific audience questions, I have a couple of questions for the presenters. I'd like to start off by asking each presenter to give a brief description of the process for accessing their data sources, including any steps for accessing restricted data. So Dr. Jabbarpour, we can start with you. Will you please give a summary of the process for accessing MEPS data?
Yeah, sure. So the files, like I said, for the national level data are actually publicly available. So if you go to meps.ahrq.gov, you can find the downloadable data files there. If you want to use state level data for the 29 states where it is available, then you do have to fill out an application, pay a small fee to go to the data center. I forget how much the fee is, something around the $300 mark. In our experience, AHRQ has been actually pretty quick with approving those applications and giving us an appointment to go in person to the data center. Once you go to the data center and do your analysis, you don't immediately remove your analysis. It has to be overseen by someone who works with the MEPS data, and then you're free to use it. So essentially, we have found that it's a pretty seamless process. The only thing that I will say that I didn't mention in my presentation, you noticed that even though the scorecard was released in 2023, we only had data up until 2020, and that's because there is a little bit of a lag. So the 2021 data, for example, will not be released until the fall. So if you're planning your projects, just keep that in mind in terms of timelines.
Great, thank you, Dr. Jabbarpour. And Dr. Kuo, will you please give us a summary of the process for accessing Medicare claims data?
Okay, Medicare claim data you can access on 3 levels. There's public data also, there's limit data, and then there's research identified data. And there are a lot of detailed information. You can go to Research Data Assistance Center, resdac.org. So they give a lot of documentation and also different level of data. The data used in my study is research identified data. So that it's not cheap, okay? So you need to get a grant in order to purchase those data. And right now, CMS also have those called virtual research data center. So you can get a very large data, work on the cloud to do that. And roughly right now it's 35,000 per year per seat. You only have 1 people can access the data in the cloud, and you can there's a limit, storage. If you need additional storage, it will cost money. And the process to get all those assets, research identified data, is you need to build it called DUA, data user agreement. And you work with ResDat to build this data user agreement. Our experience takes 3 to 6 months to get a ResDat approved, CMS approved. It's a long process, and currently we just received 2021 data. Thank you.
Thank you, Dr. Kuo. That was very helpful. And now, Dr. Larson, will you please give us a summary of the process for accessing OCHIN data? And also, if you could comment on what other comparable data sets you could have used for this type of research instead of OCHIN as well.
Yeah, so I would first direct people, if you're interested in accessing or using OCHIN data, to go to ochin.org/research. There's a lot more information about the types of data, as well as our research partner form. So if people are interested in partnering with OCHIN, and essentially the process is that you come with your general aims. Even if they're really drafty, it's really important to reach out early, because we do have a lot of partners that come to us, and so the timeline for that can, especially for newer partners, can take a little bit of time just to get through. It does require that OCHIN's Scientific Leadership Committee and Executive Leadership team need to approve any research proposals. And so, it's really good to be thinking about if your research is a good fit for health center priorities and capacity, as well as OCHIN research priorities. And those, again, are all kind of listed on that research website. And like making sure that your research has a focus on safety net clinic patients and is a benefit to them. Other data sets. Yeah, so OCHIN is part of and leads what is called the Advanced Clinical Research Network, which is one of 9 clinical research networks in PCORNet. And PCORNet's goal is really to help create a national network of representative data for conducting research. And so any of those other data sets might have been other resources that I could have utilized. The main difference between those other data sets and OCHIN, the clinical research network that OCHIN is a part of, is that OCHIN really focuses on the safety net population.
Great, thank you, Dr. Larson. So I have one more question for all panelists before we get into the specific audience questions. And that is, I'd like to ask all of you what advice you'd give other researchers interested in using these data sources, if there's anything you haven't mentioned already. So Dr. Jabbarpour, we can start with you. What advice would you give researchers interested in using MEPS data?
Yeah, so I think there's a lot of articles out there using MEPS data. So one of the pieces of advice I would give is, obviously, as all researchers do a robust lit search with MEPS in your keywords. You don't want to repeat, but also it allows you to see what the limitations are. We found that, for example, when we were trying to get the specialty of nurse practitioners and physician assistants for usual source of care, we wish we had known that it probably wasn't going to be as accurate as we thought. So that would be one piece of advice. And the other is to realize that it is good for state level estimates, which is unique to a national data set that is publicly available and has a small fee for the state level. But as I tried to highlight in the presentation, the state level estimates, the population is so small, even for those 29 states, that you can't do then state level estimates by demographics by year. So it is limited in that way.
Thank you for that advice. Okay, so now we can move to Dr. Kuo. What advice would you give researchers interested in using Medicare claims data?
First, Medicare is a billing data, not a research database. So very important is, you need to set up, we always have something we call flowchart. So very clear inclusion, exclusion criteria based on your study design. You have to think slowly and set up flowchart first. So analysts can help you to programming that to get those cohort. The second is about, Medicare is a lot of diagnosis code, but some diagnosis code may be not specific enough. So if you want to identify a disease, maybe one code is not enough. Right now, ICD-10 is very tedious. So, so finding a good algorithm, there are some publications have those validate algorithm to define certain disease, certain condition. I think those are good to find using those kind of algorithm. So CMS right now have a website called Chronic Disease Condition, ccwdata.org. So they define a lot of chronic condition and the potential, disabled condition there. So those can be some reference can be used. Last advice, I have is about, using Medicare data, you want to know what's being covered, not what not being covered by Medicare, because some people may find the rate very low and because it's not covered. So you have to understand what you want to study, what to be covered. And also you want to know a lot of, coding change, right? From 9 to 10 or provider change from UPIN to NPI. So you want to know all those coding change in order to make sure, you capture good results. Thank you.
Thank you, Dr. Kuo. That's all very helpful advice. Okay, and now, Dr. Larson, what advice would you give for researchers interested in using OCHIN data?
It really depends on the research question. I think, again, just making sure your research is a good fit for health center priorities. I guess one thing to note is that all research at OCHIN is done in partnership. So OCHIN doesn't just ship out data. This means that every project does have experts at OCHIN who know this data really well and who know how to use it, and then also kind of like helping with interpretation in the context in which the community health center context as well. So just there, you're not kind of just sent data and then you're on your own trying to figure out the nuances of it.
Great, thank you. That's also good advice. Okay, so we have a couple of questions that have come through from the audience. The first one is for Dr. Kuo, and it says, degree of collaborative care or connectedness can easily be captured by their workplace or affiliation. However, can you please elaborate how you measure degree to which decision-making process is centralized and degree to which information sharing is centralized? Were there specific questions regarding this in the data set?
So Medicare data actually do not have practice ID. So Medicare data, you have provider ID, you have hospital ID, you have tax ID. So like, for example, like our institution is, it's all under one tax ID. At the primary care clinic, we have 25 primary care clinic, and we don't know which doc, which NP, they work together. So that's why we're using this social network analysis method. And this method, this is not a methodology talk. We talk about data. So, social network analysis, they are very detailed, measurement, which is doing, and there are different algorithms to define the network and define the collaboration. So that's kind of, we're using that method on this particular paper. So if people have interest, I can send some reference to you and about social network analysis more detail.
Great, thank you, Dr. Kuo. It looks like we have one more question for you. How robust is the MPI dataset in providing accurate information on the contemporary taxonomy, i.e. specialty of providers? Is it up to date?
Okay, so the file is update, I think pretty frequently, like maybe monthly or something, and we download those data because when it's updated, so we kind of download some data, quarterly. So we have those older data because when we study Medicare data, definitely we have a gap, so we don't have most recent data. So so we have to get the Medicare data. We merge with the older, those, taxonomy code in order to match. As you're asking about how good the taxonomy code is, I think for NP it's pretty good to identify primary care, but for PA, I don't think it's such good. You can find some ER PA, but as for primary care, maybe I just feel not detailed enough like NP.
Thank you, Dr. Kuo. Let's see, the next question is for Dr. Larson. Are the OCHIN data organized into a common data model? And if so, which one?
Yes, so it is organized into a common data model, and they are using, sorry, I'm trying to remember that. They're using the PCORnet kind of framework for organizing data.
Great, thank you, Dr. Larson.
Yeah. Yep.
And then I have a question for all panelists. Are there particular tools and or statistical analyses that you use regularly that you'd recommend? So I guess anyone could chime in here.
Yeah, I think I already mentioned, just because of the nested structure of OCHIN's data, we quite commonly use multi-level modeling approaches with OCHIN data, but that's not the only modeling approach that gets utilized.
Yes, I agree with Dr. Larson. So in Medicare, we also do a lot of multi-level data modeling, like a mixed model, generally linear mixed model, 2-level, 3-level, cross-level. So those we do use a lot. And definitely with longitudinal data structure, we also using a lot of survival analysis to look at time to event outcome. Those also use very often.
And I'll say I'm probably not the right person from the Graham Center to be answering the specific analytic question, but because our work is very broad and very policy relevant, we tend to do actually simpler is probably not the right word, but a lot of descriptive analyses and a lot of geospatial analyses. One thing related to what Dr. Kuo has been talking about, we also use the Medicare claims data a lot. And one way that we have found, Dr. Kuo, to look at NP and PA specialty that may be of interest, and it's described in detail in our scorecard, is actually co-location of the providers through the NP-PES. And what we assume is that if the providers are both working together in primary care, the NP or PA is primary care. And if it's a multi-specialty clinic, we go by the proportion of primary care in that multi-specialty clinic and weight the NP or PA that way.
So I don't know, like data in Medicare, we have a zip code for each provider, and then but each zip code still several practice together. So I know, and then go down to address become very tedious. The spelling, everything, take more time to clean up those data.
Great, thank you for all of those helpful comments. We have another question for Dr. Jabbarpour. Could you please speak more about the strong validation of MEPS?
Yeah, so what we mean by that is that not only is it that the respondents are guided in terms of how to collect the data over the 2-year period during the 5 visits. It's not just blindly calling someone or showing up to their house and asking questions, but it's validated through a subsample is validated through the provider or the practice that the household says they go to. So they can go to the provider practice. I'm not sure exactly who at the provider or practice answers the questions, whether it's the provider, the office manager, who that person is. And then it's also validated through that a subset is validated through that patient's claims. So it's not 100% of the data that's validated, but enough to actually be stronger than most of the national level surveys of patients that we use.
Thank you, Dr. Jabbarpour. Okay, I don't see any more audience questions. So if you have one, please go ahead and enter it in the chat. Otherwise, I do have one more question, kind of late breaking, that I would like to ask the panelists. Oh, okay, I do see one more question in the audience. Let's ask this one and then we can tie up. What kind of incentives are offered to MEPS participants?
Yeah, I actually don't know the answer to that one. I don't know if anyone from AHRQ wants to jump in. I don't know what kind of incentives are given on the back end.
I actually don't know the answer to that question either. Mm-hmm. I'm thinking they don't have incentives, but.
Yeah. I've used MEPS data before, and I've probably written this somewhere in a paper, but I don't recall either. So apologies for not being able to answer your question. Okay, I have one more question for the panelists. As we mentioned at the beginning of the webinar, this is part of a series on primary care research, and the next webinar will focus on qualitative methods. So do you think that qualitative methods might have been helpful or useful at any point in your studies? And could it have informed your research questions going into the project? And or do you have findings that would benefit from a qualitative approach?
Yes, I will say that both our primary care spend measure and our usual source of care measure would absolutely benefit So for example, on primary care spend, why is it higher in some states than others? What are states doing with the increased investment in primary care spend? Why has it changed over time for certain states? These are questions that are more amenable to asking stakeholders who design policy, insurance policy in those states than a quantitative analysis could have answered. And then for usual source of care, for those who don't have a usual source of care, why not? I mean, I think that is the big question for us. There are some questions in MEPS that could get there, but it's not robust enough.
For the primary care team, I think a qualitative study, social network give you, some basic understanding, but you really want to understand how provider work together, like we talk like NPPA, do they are substitute because doctor is not available, cannot get appointments, so they provide care, or they are try to, have complementary skill, they talk to, patients, spend longer time, doing more health education or something, all those details we don't know in this, in Medicare data. So qualitative study will help a lot.
Yeah, it's definitely something I've thought about as a way to extend this research and something to kind of do in the future to understand whether or not patients and or providers are using different types of telemedicine and some of the barriers that they see. OCHIN does participate and lead a number of implementation science and qualitative research studies. And so the ability to kind of recruit providers, practices, or patients to participate in research is something that I think would be interesting to do in the future grant.
All right, thank you so much. We have run out of time now, so thank you again to all of our presenters and to all of our audience for asking such great questions. I'm going to turn it back over to Amy now just for some quick closing remarks. Thanks again.
Thank you, Robin. Thanks, Yalda, Annie, and Yong-Fang. Really great presentation. I also just really quickly want to thank my AHRQ colleagues who helped bring the webinar to life, and the APT associate colleagues who really planned, organized, and provided all the technical support for the webinar. Thank you for joining us and listening to all the presenters and sticking it out, asking great questions. Please know that the webinar recording and I think all of the slides will be available on the AHRQ website in the near future. Don't forget again to look for the next webinar in the series regarding qualitative methods. Hopefully you or your mixed methods and qualitative colleagues will join us for that. And finally, please do take the short evaluation poll that will pop up after the webinar closes. We'll use that to inform and improve our future webinars. Thank you so much. Have a great rest of your day.